see what it is that we're not doing well. So that 20 years after all these big major problems, we still have these huge gaps in terms of women resources. WHO estimates that we have, I think, 14 to 15 million health care workers shortage for us to achieve universal health coverage. And most of these gaps is in the African continent. So there is a long way to go, and we need to be taken this serious. My third point, before I tell you what Women in Global Health is proposing to do together with Africa CDC, and then I'll conclude. The third point has just been highlighted also by Minister Tadesse, is about the fact that 70% of the women of the health workforce is made up of women. In some places, it's 80%, 85%. We also know that the African population is about 70% of young people, 60 to 70%. Most healthcare workers, particularly frontline health workers, are not paid or are poorly paid. You have mentioned the 3 trillion of work that is done unpaid. Women are absent, invisible, or sidelined from decision-making policies within the health sector. Dr. Leah Tadesse, Dr. Minister from Uganda, Ruth, and few others are just the best examples we have of women leadership when it comes to global health in the continent. Most ministers and decision makers are men. Yet most health workers are women. The women deliver healthcare, which is led by men. So this is important to be borne in mind if we are going to reimagine the development of the healthcare workforce. Gender transformative policies are not part of the reimagination. There will be no sustainable partnership for us to move forward. Then finally, Madam Chair, Women in Global Health is in discussion with the Africa CDC to look into the different programs they have to streamline leadership within the public health, the new public health order that Africa CDC is moving forward. And we have been thinking about the young women, early career young women within the healthcare setup to move them through the leadership pipeline. I said, and we all know, Africa is a young continent, so we need to invest on women, we need to invest with young people. Our proposal is that we create a leadership program for early career young women, health workers, so that we build the sustainable workforce that we want. We actually proposed to call it after Mrs. Graça Machel, because I think we have seen the Kofi Annans, the Mandelas, the Obamas, nothing against that, but I think it's hard time that we have one of these leadership programs named after a woman. So we are looking for support, financial support. I think we are still finalizing the discussions with Africa CDC, but this is something that we think can make a difference in terms of reimagining the health workforce within the continent. I will conclude with 3 points again. One is to say there will be no new public health order without women and without young women. We really need to put women and young women at the center of the reimagination that we are making. Second point to conclude will be that we need the level of ambition that will match the size of our problems. Our problems are big, and our ambition needs to be to the size of our problems. If we put the band-aid into the problem, we will come back to a bigger problem than we had before. And then finally, gender equity needs to be at the center. We need gender transformative policies as a foundation for us to be able to move forward. Probably I've taken more than the time I was allocated, and I thank you for listening to me.
Thank you very much for those very succinct, powerful, and very needed points, and want to very much highlight that we have to be as ambitious as the problems there are, if not more, right? As we seek to move things forward. I would like to take a moment actually to begin to kindly ask for some comment from the audience, and I'd like to ask the Honorable Minister of Nigeria to please speak and to give reflections on the health workforce in the context of Nigeria.
Well, thank you. Again, the problem in the African continent is the same everywhere, I believe. Not enough workers, a lot of work to do. And now we are seeing a different problem of health workforce migration. So the question of how to get the right workforce that you need for your country, I think will have to be solved individually by each country with the opportunity we have like now to compare notes. In Nigeria, across the board, there is shortage of manpower. We have shortage at the primary healthcare level, where we focus largely on community health extension workers. We operate to 36 states, the country where each state is actually responsible for care at the primary level. It's not the federal government that does that. But the level of activity that goes on between the state governments and the health service varies, depending, of course, on the focus of that state government, and does not always align with the federal thrust. Nevertheless, the federal government does push very hard for even development, opening schools of health technology to support training of healthcare workers at primary level, and nurses and ancillary workers, professionals, radiographers, laboratory technologists, and so on. All of them are trained at the university, and doctors. Now, paying the health workers is a problem. So we have a problem of not enough workers, and those who are there are not everywhere paid on time or paid an amount that they think is commensurate. So we are working on a strategy that will take a good look at that problem across all the states of the Federation, and try and see how to improve service conditions for health workers generally, and remuneration for health workers from the lowest level to the highest level. Lately, we are seeing a lot of attrition, workforce migration to other countries. The troubling part is that a good number of them, in fact, most of them, have been trained at taxpayers' expense and leaving the country to work, or let us say serve in other places where the pay is better. It's an issue that lets us start thinking about, well, if you're trained at taxpayers' expense, I think you should probably be bonded for a few years to serve your country before you move on. The other aspect is trying to engage a health workforce who are in the diaspora. There are a large number of persons who have migrated